Right. So good morning, everyone. My name is Mariah. I am a program manager with the Colorado Health Institute. And today's meeting will be recorded and posted on the APM website. I am also here joined by Ashley Brown and Emily Luong, who are both with CHI as well. And then Zoe Pincus, who's the Quality Health Improvement Specialist at HCPF, Dr. Peter Walsh, the Chief Medical Officer from HCPF, Nathan Drashner, the Senior Consultant from Health Information Office, and Megan Riley, Director of Quality and Payment Program for Contexture. So there's lots of folks here this morning. I'm going to be moving us to our agenda now. So today we have our welcome this morning. We've got some good solid time to be able to learn about our reporting model for the APM1, the APM1 vision of rewarding PCMPs and measuring member performance. We've got a presentation from Contexture and QHN support, and then some open discussion and closing remarks. So during the meeting today, we love participation. Please participate. Ways that you can do so are sharing your comments and questions verbally or in the chat. Please, prior to sharing, if you could say your name and organization and disclose any sort of financial interests that might be appropriate. And if you would like to comment verbally, just raise that little hand function in Zoom, and we'll invite you to share. And then again, because we love feedback and we love discussion, if you do not get a chance today in the meeting, we'd love for you to submit any additional feedback no later than Tuesday, the 17th, to focusgroups@coloradohealthinstitute.org. And CHI will be gathering that information at Colorado Health Institute and summarizing it to be shared with HCPF. Okay. I'm going to pass this next piece off to Zoe Pincus, and she's going to go through the overview of APM1 and quality reporting model.
Hey everyone, my name is Zoe Pincus, and I am the Quality Performance Specialist at HCPF. And work a lot on our primary care APM. So just a brief overview, since I'm sure many of you are very familiar with our APM1 model. The APM applies to providers designated as primary care medical providers in the Accountable Care Collaborative. And it's a mandatory program for PCMPs who have 500 or more attributed Health First Colorado members. Most of the components are the same for all PCMPs, but there are a few important differences for our federally qualified health centers, and those differences are described throughout our APM guidebook. In the APM, PCMPs report on 10 quality measures each year from our APM measure set. There are 3 mandatory measures and 7 measures that get to be self-selected by the PCMP. PCMPs report on these measures and have to demonstrate performance and improve performance in order to get a potential rate change for the practice for the following year. Next slide, Mariah. We have 3 different measure types. We have structural measures, which focus on process improvement and are pass-fail. Examples of structural measures include integrated behavioral health care, alternative encounter types, or patient satisfaction. We also have administrative measures, also formerly known as claims measures, and are based on Health First Colorado member claims. Examples of these measures include child and adolescent well-care visits, or screening for depression and follow-up. And then we also have our electronic clinical quality measures, also known as ECQMs, and those are calculated directly from a PCMP's electronic medical record and reflect the impact of the healthcare services or interventions on the health status of a PCMP's whole patient panel. So some of these include diabetes, hemoglobin A1C poor control, or high blood pressure control. In general, ECQMs and administrative measures are worth more points in the APM than structural measures, and point values are used to incentivize providers to select ECQMs or administrative measures over structural measures. The way providers earn points varies across the different measure types, which we just talked about a little bit. Structural measures are pass-fail, and then administrative and ECQMs are based on close the gap methodology, which is a PCMP must demonstrate improved performance by 10% from their own baseline towards the established department goal for a measure. In program year 2023, which we are slowly wrapping up, we currently have 28 measures in the program. By measure type, there are 9 structural measures, 8 administrative measures, and 4 ECQMs, and then 7 measures exist both as an ECQM or an administrative measure. This allows providers flexibility in how they are able to report data. However, PCMPs are limited to selecting either the ECQM or administrative version of a measure, so you're not allowed to select both. And then there is a limit of 100 points that can be earned from structural measures. So we're just going to go over close the gap calculation. I'm sure this graphic looks very familiar to a lot of you. So structural measure points are earned all or nothing, while points for administrative measures or ECQMs follow the close the gap calculation based on a statewide goal set by the department for each measure each year. So to receive full points for a measure, PCMPs are expected to demonstrate improvement by closing the gap between their own baseline performance and the department's statewide goal by 10%. So thus, PCMPs are measured against their own historical baseline rather than against other practices during the same period. If a PCMP's performance is at or above the statewide goal, the practice will receive full points for that measure. So in this example, the bar represents meeting 100% performance on a measure. The department goal for this hypothetical measure was set at 70%. So if a practice's historical baseline was 40%, the gap from performance to goal is 30%. So during the program year, the practice must improve 3 percentage points to get to 43%, to have closed the gap by 10% and earn full points for this measure. Payment adjustments have happened over the last 2 years. So, and this is kind of how points are earned, or not points, the rate changes. So if a practice has between 151 to 200 points, they earn between 3 to 4% of the enhanced rate. And it is a sliding scale. So the closer you are to 200, the smaller of a rate reduction you will see. And then it kind of goes down from there. But you will never be below 100% of the Medicaid fee-for-service schedule. So all PCMPs had historically been receiving the maximum enhanced rate of 4% over the last several years. But the APM model always intended to provide more funds to top performers. So in this example, practices A and B. Practices A and B will earn the enhanced rate, while practice C, in this example, will earn less than the enhanced rate, and practice D, in this example, receives the baseline rate, so 100% fee-for-service. In this example, since practices C and D both earn less than the enhanced rate, those extra funds then can be redistributed to practices A and B for earning at least 200 or more points. And now we're going to go into a little bit about our APM1 vision, and I am going to pass it over to Dr. Peter Walsh to go over the next few slides. Or maybe I should pause and see if there's any questions. Ashley, were there any questions in the chat or comments?
We just had a question pop up about, can you use any tool to measure patient satisfaction and experience? And I believe the answer is no. It's a very specific CAPS measure. Is that correct?
Zoe, do you want me to take this?
Sure, go ahead.
Yeah, this came up, I think, in our previous meeting. It's a really good point, and I'll say it, an end game in our future. I think the next slide speaks to vision, but it would certainly be part of it if we thought it was achievable. Our current challenge is, well, there's several challenges, but with it, whatever system you pick to measure patient satisfaction, it is still going to be very challenging to measure it in what I would call low volume providers in terms of Medicaid. And so we didn't previously collect our CAPS data and try to, I'll say, understand it and aggregate it by provider. But our numerators and denominators were too small to basically make meaningful or statistically significant conclusions regarding providers. And so we would have to ramp up, I would say, very, very substantially our sampling to be able to actually make conclusions about, I'll say providers in our bottom or our low, in terms of volume Medicaid. And so it's problematic is what I'm trying to convey. If you have any experience on the hospital side where CAPS are used, I have some experience where we tried to utilize this to understand provider performance for some of the work that was going on. And to make a point, it was very difficult to make any conclusion at anything other than a yearly basis, and that was even problematic. And providers would swing from being the best provider in the country to the worst, literally month to month sometimes. So our current tool that we use is the CAPS survey. That's CMS directed, and that is what we're using. We're hoping that CMS makes a decision to migrate to a different tool, a patient-centered, basically a type of satisfaction experience tool. If they do that, it's a shorter set of questions. We might be able to expand and sample at a much larger rate. Sorry, that's a really long answer. But the short answer is, for large groups, it would be possible, but it would be really challenging for smaller groups. And I'd be glad to take a follow-up question if there is any.
That's a great answer, Pete. And I did drop the link. So CAPS, I guess, yeah, to clarify Barb's question, CAPS is not used in the APM program. I did drop the link for our structural measure specifications. So the main thing we're looking for in the patient satisfaction structural measure is for a practice to have a patient and family advisory council. And then so this one is very difficult for a lot of practices, and we see it selected not as frequently as we would like because it is hard to meet.
And I want to acknowledge that it's a really good question. It's important, but and we're continuing to think about it, and it may be possible in the future. Do you want me to proceed, Zoe?
Yeah, unless we have any more comments or questions on this one.
We have a follow-up from Barbara Bishop asking if CAPS is allowed for APM1 or does it have to be a PFAC? And I believe this is a structural measure, but Zoe, jump in here.
Yes, I think I kind of just answered it, but yes, it has to be a PFAC, not CAPS.
Great.
I didn't write the structural measures.
Let's continue.
So next slide, if you could, please. just want to spend a few minutes talking about what's our vision moving forward, and essentially follow up on two key points in what we ended our conversations on last year. This is a representation, I think, of the last slide. We want to continue rewarding PCMPs that go above and beyond. That is, and those who have solid performance as well. That is a long-term goal. We are, though, and this is, I think, not what we're going to be doing this year, to be very clear here, but we're talking about vision moving beyond now. We are going to transition to incentives based on Health First Colorado member performance. And this is, as we've mentioned, obviously it's the APM program for Health First Colorado. And currently, as most of you know, when we use ECQM data, we're accepting essentially reporting at the whole panel level. And our long-term vision, frankly, and long-term as in our next iteration of APM, is not to be in the same point. And so to do that, we're going to have a number of slides, and Nathan is going to be making some comments regarding, I'll say, just data elements, and that's why contexture's on in this presentation as well. To do that, though, to do it with, we can do that with administrative measures, and that is doable. And there, for the core measures, I'll say in our future program that will be included, we'll be able to do that. But we'd like to make ECQMs available to providers as well to decrease their burden. And so to do that, though, we're going to need the supplemental data to essentially understand when they do ECQM reporting, who are and who are not Medicaid members. And one of the other things we obtained from it also on the supplemental data sets is race and ethnicity information. But we need that supplemental data to understand who the Medicaid members are in that data set, and then for our quality and our analytics team to make calculations regarding our overarching Medicaid performance for given measures, which we are mandatorily required in 2/3 of the cases starting in December of 2024. We will have to report the measures to CMS. So just want to, we talked about this last year. I don't think everybody captured the fact that this is important to the department. This is not a now thing for this year in APM1, but we don't plan to continue paying for overall panel performance in our future programs. Next slide.
And I am going to jump in here and just go over our ECQM point structure, but I did see a question pop in the chat from Julie Reskin, who said, when you say go above and beyond, can you give an example of what this looks like? Which is in reference to this slide before. I think we are looking to reward our providers who, I know quality is not the only indicator of how these quality measures are not the only indicators of how practice does and the care they provide to their patients, but it is a big way, and that's how we monitor it. So to me, a practice that goes above and beyond is maybe a practice that's closer to that 300 points, or I don't know, 250 points, and not at 196 points. I don't know if that's probably not the best example, but if you're going from like a points perspective, what is the practice doing that is earning closer to 300 points than a practice who's under 200 points? I don't know if Pete wants to chime in at all.
Yeah, Julie, it's a great question. In terms of, again, we're talking future APMs here, which are literally going to be designed over the next and piloted over the next 2 years, not the current program. So what we do know at this point is, just to be certain on what is known, is that our future APM programs, and by the way, we have metric and quality incentives in a number of programs that we're going to try to align to the maximum extent possible. But with regard to APM, we intend to basically work off of the DOI list for I'll say primary care APMs that is in the process of beginning rulemaking. There's been almost a 2-year stakeholder engagement process leading up to this point, and there are draft lists that include 7 metrics each, one of which is, by the way, what I'll say, patient satisfaction, patient experience metric. And 6 of them are quality measures for 6 for adults, 6 for children. We intend to use those as the center of our program. And we're hopeful that what DOI is proposing is what ends up in the final rule. They're all core measures. They're an important subset, the 12R of the 60 plus, I'll say, core measures that exist for Medicaid. That's what we know. All right. Now, in terms of program design, though, we have not worked out, because we're going through a whole design process and stakeholder engagement process, what the final, that's the metric part, but there are many elements to a quality incentive program. First and foremost, how much is at stake? Second key issue would be, again, what subgroup are you using to measure it in? I've already spoken to the issue. We intend to use Medicaid members because it's a Medicaid program. Third big piece is what the goals are. And we realize as a department that how we approach the goals to date has been useful, but probably needs enhancement. And to your point, I would just, it is not decided yet what level of performance will be required to meet X level of, I'll say, incentive. I will say, though, that if you look at all the, and I'm going to use 56 because 4 of the core measures speak to long-term care, but of the 56 that speak to I'll say non-long-term care core measures, probably we still have difficulty measuring about a quarter of them, substantial difficulty. Of the 75% we can measure, in less than 20% of those are above what I would call the national mean. And so we as a department recognize that saying, for instance, if we were at the national 5th percentile performance hypothetically for a measure, we're going to, for instance, pay 10%. If you move that 10%, we're going to incentivize. We're obviously talking about whether that's going to be adequate. And I would just say that at a minimum, the department would like for Colorado performance to be at the national mean for these core measures. So long answer to, it hasn't been determined yet. We know we have to work. This is a really important issue, how you design the program. It hasn't been decided yet. And again, stakeholder engagement and program design is underway. Literally started in August. And I'm sure you're welcome to engage in that process because again, I don't think moving from 5% to 6% or from 5 to 10 to the 5th percentile to the 10th percentile is, and with a track that it would take you, 10 or 12 years to get to the national mean, is probably what we ought to embrace in the future. Back to you, Zoe. Unless Julie has any questions, follow up.
Julie says, thank you. So I think we can move on. Thanks for that question, Julie.
Okay, so to keep us moving along, we're just going to review our current ECQM point structure before we kind of get into the next piece of our conversation today. So to earn full points for an ECQM, you must report 2 years of data with at least 20 patients in the denominator. And ECQMs are PCMP's full patient panel, so not just Medicaid. And they must close the gap by 10% or have met the department goal with at least 20 patients in the denominator. To earn partial points for an ECQM, or between 50 to 100% of the eligible points, a PCMP must report 2 years of data, so the baseline year and the program year, for at least 20 patients, and demonstrate gap closure between 5 to 10%. To earn just 50% of the eligible points for an ECQM, a PCMP must report 2 years of data for at least 20 patients, but did not necessarily demonstrate at least a 5% improvement, or they reported 1 or 2 years of data for between 1 to 19 patients, regardless of performance. And then we also have a way to earn 25% of points, which is basically to have the measure turned on in your system, but you're not reporting a denominator size of 0. So to move us to our next slide, we are proposing to remove rewarding 25% of points for ECQM for practices who report zeros in their denominator, either because their measures aren't working correctly on their system or because their denominator is actually 0. PCMPs really need to have a reportable denominator to select a measure, or they need to select a different measure. Changing the requirements for participation in 2022, when we changed the eligible criteria, should have really eliminated this situation. And since ECQMs are all payer, it should not really be difficult for a provider to have 20 or more patients in the denominator. It should also really be noted that only 16 measures among the 300 PCMPs that participated in 2022 fell into this bucket. So the impact of removing this point criteria would be very, very small. And if we just want to jump to the next slide, we are going to see, we have a discussion question.
Yes, we're gonna take a Zoom poll, just sort of a pulse on how folks are feeling. So the question is, do you have concerns with updating the ECQM point structure to remove awarding 25% of the full ECQM point value when the reported denominator size is 0? So I'm gonna throw up this, it's not a great way to say that, but I'm going to put the poll, launch this poll for us all here. And we would love for you to participate. And then we'll open it up for discussions. We've got about 24 of 87 folks participating. A lot of folks are saying, about 60% of folks are saying that there are no concerns. Some have minor concerns, about 30%, and then about 11% have significant concerns. Would anyone like to either come off mute or type something in the chat for their minor concerns or significant concerns? Who chose that option? Barbara. We love to hear.
You. Thank you, Mariah. Yeah, Liz, I'm wondering, and I hope this makes sense how I'm going to say it. So with the public health emergency ending and Medicaid patients are, in flux. So there's, some are dropping. If we're focusing specifically on the ECQMs and the Medicaid population, my concern is that maybe at the beginning of the year, PCMPs are assuming, or maybe they're looking at their previous data and assuming they're going to have enough in the patient population. And then all of a sudden, let's say that population drops, which probably won't be a huge percentage, but if it does happen, that PCMP is at risk of losing money then, instead of getting even just a 25%. So that would be my only concern. I know the chance is low, but still there's that chance, especially for our more rural systems.
Yeah, and Barb, we definitely understand that, and that's why we still are gonna have our other partial points. We're really just, this 25% of points is really talking about denominators of 0.
Yeah,
So I don't think that's likely to happen. In some circumstances, over this last performance period, we're kind of just wrapping up. It really seems like providers didn't take the time to make sure their ECQMs were working correctly in their system. And that's why, they're still getting a percentage of points, but we really, as we scale up to this next, version of APM and, moving towards Medicaid only, ECQM reporting, we really just want to make sure providers have, are selecting measures that work with their patient population. And if you don't have any diabetic members, for example, you probably shouldn't be choosing a diabetes measure to focus on. It's probably unlikely that you don't, but we're really just trying to get practices to report, make sure their ECQMs are also just working correctly, right, in their system, and that they don't have a denominator of 0. So
thank you.
see quite a few comments coming in.
Yeah, would you like me to read those for you, Zoe? I can do that.
Sure.
Yeah. So Tina Gage said, good point, Barb. Thank you, Tina. We also have Dawn. They said the Medicaid drop-off is not updated frequently enough. Will it have impact on the ECQM overall? And do you want to speak to that, or is that more of a...
Maybe Dawn can chime in. It felt a little more like a statement, which I agree with. I don't think it will really impact your ECQMs overall.
Great. And then Jane Reed wrote, this won't impact the 25% given to practices that can only report 1 year, right? That would reduce practices that are willing to take a chance.
I will definitely need to double check the guidebook to make sure. I think that's something we consider, is if a practice can only provide 1 year of data. I think they still get 50% of points if they can report 1 year and have a denominator greater than 20. I think they still are eligible for 50% of points, not 25%, but I'll double check on that, Jane. We don't want to take that away. We just want to take away. We really just want to eliminate providers reporting zeros.
All right. Michael Morissette said, I'd be interested to know how many health centers reported ECQMs with denominators of 0. The more there are, the more concern I would have with removing it.
Yeah, so Michael, I have to check on how many practices it affected. It only affected 16 measures across, if you had 300 practices and they each selected 10 measures, right, you're like, is that 30,000? Or 3,000? Sorry, my math is not good. That's like 3,000 measures selected overall. So that is a very tiny percentage. I don't know off the top of my head how many practices, but it was 16 or less. And it was only maybe 1 measure, or 2 per practice. So 16 practices at most for 22.
Thank you for that clarification, Jolene. I think you actually answered one of the other participants' questions about 0 to 19. The 25% is specific to denominator of 0.
Thank you, Jolene.
And then Don also had a question about which measures are in question. This would only be for ECQMs, and this change would only impact denominators that are being reported at 0.
And it looks like we went through our comments and questions. And we can move on to our next slide if folks are feeling okay. All right.
All right, I think that's me this time. I think I've met many of you. My name is Nathan Drashner. I work for the department on ECQM measures. I've been doing that for about 6 years now. I actually started when we first developed the idea for the program under the state innovation model. And as we transitioned to APM 1, I've continued those efforts as well. I'm going to talk to you a little bit today about what we found over the last year, looking at Medicaid only in comparison to the traditional overall ECQM calculations. First, I'd like to really thank you guys, those of you who were able to report. I know it was a challenge. It wasn't real easy. This is kind of new and innovative. We hadn't done this before. So those of you who were able to report and help us out to get a better idea of what the environment looks like for a Medicaid only ECQM world, really appreciate it. We know it was a challenging topic and it wasn't easy. As has already been mentioned, our intention is we're going to require PCMPs to report supplemental and specific data on the Health First Colorado population for program year 2023. But we are going to continue to pilot the Medicaid only reporting. We're not going to transition, just to repeat Dr. Walsh's position. We aren't transitioning to a Medicaid only ECQM reporting world yet. But based on the data that I'm about to present to you, we really, that's where we're going to go. That's what needs to happen. So we would like to note some limitations of the data that I'm about to present to you. We do have a fairly small sample size. We only ended up with about 30 measures. Reported on 30 practices, I guess, would be a better explanation of the measure on the measures. So that was a result of a lot of zeros. Unfortunately, a lot of you, I think it was just a little bit beyond what you were able to do. We got a lot of zeros and we got a lot of Medicaid only measures that we know aren't even possible in relation to the overall ECQM report, in the sense that there were more non-compliant patients in the Medicaid only measure than there were in the overall report. So you couldn't have, the number that was reported to us for Medicaid only just wasn't possible. We need to kind of move away from that due to the fact that, that might indicate that we have a somewhat biased sample that we're going to look at today. Maybe we're just looking at really high performing practices. There's all sorts of complications that are created based on the fact that we don't get good data. And we understand that this is probably pretty technically challenging. That's part of the reason why we have Contexture here today. They can talk about what QHN and Contexture and CCMCN, for those of you who are FQs on the call, might be able to do to help you with that. We've seen a lot of success with the efforts. They're provided funding to help you work through this challenge and be able to move forward. Another item that we probably should mention is that what you're going to see today is a mix of manual and electronic reporting. So some of the measures that you're going to see were reported manually and some of them were reported electronically. Initially, we'd really hoped to be able to do some comparisons of that, but our sample size just wasn't large enough. Really, the sample size that we have, we can just kind of look at things at a pretty high level. So without further ado, the measures we're going to be looking at today are the required measures, just so everybody's aware. Go ahead and go to the next slide, please. We'll go ahead and start with controlling high blood pressure. So just to explain how we've done this, you'll see numbers across the bottom. Those are so what we have, the light bar is or white bar is the overall ECQM that you've been reporting for years. The dark bar is our Medicaid only reports. And these are practices, so they're paired together. So we put numbers across the bottom in case we wanted to have any conversation, and that way I can reference to them. If you guys have questions about any of these specifics later, feel free to say, hey, what's going on with practice number this on this slide, and I'm glad to help and answer any questions you might have to the extent that we can. But essentially what we've done is paired up the practices that reported both Medicaid only and an overall number, and to kind of show everyone the distribution. This is still a very small sample size. This is 32 measures on this 32 practices on this particular measure. And as we're aware, there's over 300 practices in the program. So this sample size is, and that's really what we got to drive toward, is getting a better sample size so we can make better decisions as we're moving toward the transition. So the good news, though, is what we kind of found is that there really isn't as big a difference as some people anticipated. Actually, on this particular measure, if you average out all these scores, I mean, there are outliers. I mean, if you see, practice 14 performed significantly worse on Medicaid than they did on the overall, but there's also outliers the other direction. Practice 29 performed better on Medicaid only than they did on overall. Overall, if you average all these together on this particular measure, they're both averaged at 69%, a rate of 69%. If you ever average these all together. So we really didn't see much change on this one. But we did see some variation on the next. If you could go to the next slide. This is childhood immunization status. This is actually the smallest sample size of the 4 that we're going to be looking at today. You'll see quite a bit of variation. This is a really challenging measure. We understand that. We have quite a bit of variation, and it's also the smallest sample size. But it's also a really important measure, as we're all aware. Childhood immunization status is pretty critical to the health of our children in the state. So, this is an example of where things are probably not going quite as well. This data, though, provides us the opportunity to work with Contexture and QHN and really focus on these measures. This is why we need this data, and we need a bigger sample size, because that gives us the opportunity to, devote funding to it, to have better conversations about it, really focus in on it when we're trying to do our quality improvement efforts across the program. So can you please go to the next slide? Next slide is diabetes, hemoglobin, A1C, poor control. Like to remind everyone, this is an inverse measure. So high numbers are bad, unlike the other slides where, high numbers are good. We don't want to see high numbers. This is the largest variation we've seen, unfortunately. And this is part of the reason why we really feel like it's critical to move toward Medicaid only reporting. We need to know if our patient panel specifically is performing really poorly. Unfortunately, we still don't have a huge sample size. It's only 30, but this type of result is concerning. And this is really a big part of the reason why we need to really just look at our patients going forward. We should also note that there is a lot of variability in the specific measure, meaning that, there's, you have practices that are reporting every single one of their patients are in poor control. We do suspect there's probably reporting issues going on in those cases. And then, there were also a lot of practices that just reported zeros on this one as well. Numerators, of 0, or, the numbers that we knew weren't possible. And as a result, we dropped those reports out. If we could go ahead and move to the next slide. It's the last measure we're going to look at today. This is another example screen for depression and follow-up plan, where we really, while there is some variability in the individual measures, overall, for overall performance, we were looking at 29%, and for Medicaid performance, we're looking at 31%. We did, as you take all the measures, there's 34. It's not a lot of difference. And in fact, overall, practices that reported this measure actually did better. 19 of the 34 practices did better on the Medicaid only score than they did on the overall score. They would have performed better using the Medicaid only. More practices would have performed better using the Medicaid only score than the overall score that we actually saw on this particular measure. So, can you go to the next slide, please? So we're going to be making some programmatic changes to try and encourage more reporting. Just as last year, we didn't talk about it as much, but it was a requirement. We've got to have you submit your Medicaid only ECQM data for 2024. This is, we've got to be able to have a sample size that is significant enough for us to be able to make responsible and fair decisions to everybody in the practice, or to all the practices that are participating in the program. The only way to do that is to make it a requirement. We're glad to support you in that effort, though, by funding Contexture and QHN and CCMCN to set up reporting. We have a really good opportunity here. We're pretty unique of all the states. I mean, not a lot of states do this, to have such a good HIE partner that's willing to really dig into this and help us develop a solution that can work for everybody and give us good numbers. The big key takeaway from all this, though, is we're going to use the data this next year to determine the ability and viability for PCMPs to report ECQMs versus administrators in future program years. What that means is if we get a bunch of zeros back, unfortunately, on a Medicaid only side of things, we just can't allow you to select ECQM measures in future years. We've got to be able to know that the number that you're going to be able to report when we move to a Medicaid only number is realistic and actually working correctly. So view this as a test year to figure out what's going on, and give us an opportunity to really know as a state and also your practice the ability to actually report the Medicaid only numbers. We have the HIEs on board to help us out, and unfortunately we just won't be able to allow you. You'll be required to use administrative measures if we don't have both a Medicaid only report and a overall report that are in alignment with each other and function in a way that makes sense. So I do believe we have some questions. I'm sure there are a lot. I saw it pinging on the side of my screen as I was talking. So
Yeah.
Few comments and one question. Thanks,
Okay.
Zoe, for jumping in on Heather's comment about the immunization status and the inclusion of flu vaccines and pharmacies in there. Heather, let us know if you have any additional follow-up on that point. Sarah Nouse also mentions that the reporting of CPT2 codes are vital to this measure, and I missed when that comment came in, so I'm not sure which measure it is. Sarah, if you can maybe respond to your own comment with which measure you're referring to there. And then a question from Jane. Can you review the barriers that are popping up most often in order to report?
I can't, but we have our wonderful HIE partner here who can. Megan's going to present on behalf of Contexture and QHN, and she can probably maybe touch on that a little bit when she's talking through the workflow that they work through.
Yeah, great. All right, let's keep going to get to that, and hopefully that will answer our question.
Yeah, so as I mentioned, we provide funding to the HIEs actually to provide you technical assistance in the setting up electronic connections. And as I mentioned before, please use this program year to ensure your ability to data share and your ability to report Medicaid only files. Megan's going to talk a little bit about how they do that. Megan, if you would please mention some of the challenges you run into on some of those measures I just presented. We've had a lot of success on this, and they've been a great resource and a great partner on this. So with that, Megan, I will turn the floor over to you.
Thank you, Nathan. I appreciate it. I have met most of you on the phone, but I am Megan Riley. I am the Director of Quality and Payment Programs here at Contexture. A lot of you are familiar with the electronic reporting solution through Contexture QHN and CCMCN, but I will touch base on a little bit, and Jane, I will be sure to touch on some of those barriers to reporting and how we can help support those. So practices that elect to send their continuity of care documents to Contexture and QHN can utilize the electronic reporting solution, which means that our HIE teams utilize those continuity of care documents to extract that ECQM data. We validate the ECQM data, and we work with your practice and your EHR vendor to improve the accuracy of the data on those continuity of care documents. So those utilizing the electronic reporting solution also receive technical assistance from our teams. So our teams can support practices on data issues by helping with mapping of correct codes within the EHRs and working with your EHR vendors to ensure the data elements are again included on those continuity of care documents. Our teams provide guidance to the practices to improve the data, evaluate the practice workflows, review the ECQM specifications, and validate all the data and provide support in the event of an audit. Ongoing data validation is completed as the team provides feedback reports and gaps in care reports to practices, which is done at least 4 times per year as part of the electronic reporting solution. Our electronic solution can support the supplemental ECQM data requirement specific to the Health First Colorado population. We recognize that not all EHRs have the capability of reporting Medicaid-only ECQMs. So both Contexture and QHN built a solution that utilizes the attribution list. And so we match up the attribution list to the practice MRN list that's created from the continuity of care documents sent into the HIE to determine if a patient has Medicaid, and which will tell us if the patient should be in that initial population for the measure. So touching on some of those barriers before I go into some examples of technical assistance and improved measures, I would say the first one is not all EHRs can connect, but I think it's critical to have conversations with these vendors. And Contexture and QHN teams are happy to jump on calls with those vendors and the practice to have those conversations of why we're looking to connect, the importance of getting this data into the HIE, not only to support this, but also provide the data within the community. And then we have seen over the years where some of the data does not initially come on into the CCD, but that's where the technical assistance team can get on those vendor calls with the practices and have those conversations with the vendors to be able to capture that data onto the CCD. And I think I'll touch on some of these other barriers with the technical assistance in the next slides. You can go to the next slide, that'd be awesome. Thank you. So this slide is specific to childhood immunization. I know this was touched on in the chat. So the focus of technical assistance for childhood immunization was supporting the identification of patients and need to outreach to complete their immunization series. So our teams became knowledgeable on the workflow for reconciling the vaccines within the EHR against the state's immunization registry. So like that initial hepatitis B, those flu shots, where they may be getting them elsewhere. If they're in the registry, it's critical to put them in the EHR so that data can be seen on that continuity of care document. And then in addition, it's also important to understand the changes in the immunization measure with the CVX code updates year after year and other updates for clinical quality measures year after year. And we can help support practices in understanding those yearly changes and make those workflow changes if required. Next slide. So our next example is depression screening and follow-up. So Contexture and QHN teams worked with our practices to utilize the appropriate coding for depression screening. And we know that this measure requires identification of a positive or negative screening. And if the screening is positive, then the patient has to have a follow-up documented in a discrete field. So that discrete field is critical. So we found that many practices were putting it in the plan, or if it was in a discrete field, it wasn't coming over. So working with those vendors so we can get that SNOMED and those link codes over onto the CCD so we can count that in the ECQM measure. So again, utilizing an electronic solution, practices will receive our technical assistance support from our teams. And if practices are sending this continuity of care documents to Contexture and QHN, we can support the supplemental ECQM data requirement specific to the Health First Colorado population. questions that I can help answer.
We don't have a question in the chat per se, but we do have a comment regarding, we have heard from pediatricians that the anti-vax movement has been more influential, making it harder for community practices to move that metric.
HCPF team, I don't know if you want to address that question or statement, comment.
This is Pete Walsh again here. I just say we've obviously heard the same thing, and we're going to have to take that into account as our program moves forward. But yes, vaccine hesitancy has been a real challenge, I think, for all providers.
Thanks, Dr. Walsh. And then Don in the chat said, Practice Fusion has multiple laborious processes to receive total credit for this measure. If one step is missed, we do not receive any credit for the measure at all.
I'm not entirely sure how to answer this other than I know Practice Fusion is a little more difficult for ECQM reporting. Maybe Megan can speak to that better. If you're really struggling with a certain measure for ECQMs, of course, we don't want to discourage you reporting the ECQM, but if you're not confident in your EMR to report a certain measure, depression screening and follow-up is one that we have the administrative measure equivalent for, which is based on claims data and is calculated by our own data section. So that is always an option for this measure as well as others. Pete.
Yeah, just want to, I think the comment was made earlier in the chat. To Zoe's point, for this measure, which is depression screening and documentation of a follow-up plan, to be specific, this is one where G codes are really critical. Okay, I think someone made a reference to which ones are they important to. Big picture for CMS core measures, I think the ones that really stand out big, which aren't necessarily in our required measures at this point, but hypertension, there are appropriate codes, diabetes are appropriate codes. In this one, there are appropriate CPT codes, which, if provided, allow accurate calculation of the administrative measure.
I also see a question from Tina. She is curious if data is collected on the specific vaccinations that are not completed for this measure, such as flu. So at least in the administrative data version of this measure, we collect, the denominator will be the same across all those that are required for combo 10. And then the numerator is those that have been completed. So we really, maybe a few less flu vaccines are completed within the measure. So then, since it wasn't completed, it's not feeding into combo 10. But it's really across the board. I can't say flu is the reason why you didn't complete that measure. Pete, did you want to add to that? Or Megan?
Yeah, I don't believe Nicole is on the call. Is that correct, Zoe?
I believe she is.
Yeah, she can probably comment, but I don't think flu has been our long pole. There's issues across most with most of the vaccines in combo 10. The other thing, though, I just want to talk philosophically at a higher level is, from a department perspective, we're trying to get away from what I'll call homegrown measures and/or significant modifications of federal measures we're required to report on. So philosophically, as we pick measures for our future APM program, again, which will be off the DOI list, which is in the process of rulemaking as we speak over the next 3 months. When that list is decided, one of the things that DOI is shooting for, and I think the work groups that have participated in stakeholder engagement there have indicated is providers would prefer, I'll say, a single definition of what that measure is. So therefore, for the vast majority of measures the CMS uses, they're based on HEDIS specifications. There's at least one exception I know of where there's one code included different, which by the way makes it a different measure. But we're trying to get away from non-standardized measures for a variety of reasons. So, but Nicole, do you want to talk about the specifics of Combo 10 and the profile for individual vaccines?
I don't actually have the individual vaccine data in front of me, so I can't speak to which one is bringing the number down.
Yeah, I think MMR is the challenge, but again, I don't have the data right in front of me. And for, I'll say, the adolescent combo, human papilloma is the other one. So that is challenging to meet as well.
Yeah, Tina, I can look up some of that data. I think just in general, reaching combo 10 is what's the stretch. So there's so many vaccines within such a specific amount of time for each one. So I think that's why combo 10 is particularly hard. I don't know if it's necessarily attributed to one vaccine over another. It's just the whole continuum of all those vaccines in that short time period.
And from the ECQM perspective it's very important to reconcile the data, but also when moving like the vaccine series from like 3 or 4 shot series, it's important because the codes shift. And so if you're still using the 3 series codes and you're now shifting to a 4 code series, then it's important to make the shift in the codes as well in order for that data to be captured.
And Megan, we have a question for you about the QRDA files versus CCD documents in the chat. Is Contexture considering ingesting QRDA3 files for this program? The CCD documents we send don't account for breast or cervical cancer screenings as well as many A1C values.
So right now we don't have it on our roadmap to ingest the QRDA3s. I won't completely leave it off take it off the table, so I can take that back internally and make suggestions as we were moving over to the KPI Ninja platform. But currently, as of today, the answer is no, unfortunately.
Okay, thanks for that clarification. Nathan.
Well, you guys don't ingest those QRDA3s. They are allowed to use those QRDA3s for manual reporting, correct, Megan? So, well, correct. It's not your technical solution.
Correct, right. Yes.
Okay,
correct.
Thank you.
Great, so that could be one option. And then we have a question from Jane that I think actually helps us segue into the open discussion portion of this morning's meetings. Jane asks, can you address possible concerns around equity of the program for practices that have EMRs that are unable to report Medicaid-only data, where the alternative is administrative data that is not easily available or actionable? Zoe.
So I believe the requirement at this time is for practices who are electronic reporters to be able to submit that Medicaid only file. Maybe Nathan can correct me if I'm wrong. And of course, we want all those manual practices to report their Medicaid only, but at this time, I believe it's only required of electronic reporters.
Yeah, we haven't set up the requirement that beyond what we get from Contexture, but I think her question was broader than that. I think it was probably addressing what we're going to do going forward. How are you going to deal with Jane? Am I thinking about this right? Or you're asking like what happens when it becomes a requirement from everyone?
Yeah, I think we've seen a lot of struggle with EMRs in general in just reporting all payer data, just getting that information over, everything from the follow-up piece in Epic for depression screening, or there's lots of different measures that have that have struggled based on the EMR and the way that the EMR is set up. And so my concern when I start hearing from Megan that there are EMRs that will not submit Medicaid-only data, or that information is not shareable, even in an electronic format. And I know that they've put in some sort of kind of fix for that, but where that becomes a concern, it just adds one more level of those that have the financial wherewithal to select an Athena or an Epic or a higher end EMR are better suited and more likely to succeed in this program than those like Dawn who have Practice Fusion and are really limited to what they can report out in general. So I see this as a building concern over as we kind of move towards this type of additional supplemental reporting.
Thanks, Jane. And Megan, I don't know if you want to speak to the differences between EMRs. I think what I heard, and I'd love for you to clarify, is that some EHRs are definitely easier to work with, but it's possible for all of them to submit this data. Am I hearing that correctly? Or are there EMRs out there that just, it's not possible to work with them in this way?
So not all EHRs have Medicaid only reporting within their system. And so if we can get continuity of care documents, we have built where we can support that supplemental ECQM data reporting based off the attribution list and the continuity of care documents that are sent over to Contexture. So we would have to, like for Practice Fusion, with our HIS connection that's being built and going over to the KPI Ninja, there may be some additional resources and tools we can use to connect even more vendors that we have had challenges with in the past. But there are some vendors that we will need to have a continued discussions with to try to get them to connect to an HIE. And then continued conversations with these vendors to get some of that data over to us with that technical assistance. If it's the manual reporter and you're reporting out of your EHR, some vendors can and cannot support like the Medicaid only, and that's where we would be able to support that.
Great. Thanks, Megan. And I think that's why it's so important. We're so glad that you could join us this morning. We realize this is a journey that we are all on together. And the department has made resources available for practices to work through some of these technical issues with our partners, Contexture, QHN, and CCMCN, to really dig into those details and move this work forward. Anyone from the department want to add on to that? All right. Jane says, thank you. All right, let's move into our open discussion. We have just a few more minutes left in our time together today. So we've already started talking about these questions, but now is the time, if you haven't chimed in already, to answer what are the potential challenges for PCMPs and reporting Medicaid only ECQM data, and how can HCPF and its partners support PCMPs in addressing these barriers? We're hearing some things already. We'd love to hear additional thoughts that we haven't discussed yet. And we also have a question in the chat from Christy. For practices that report ECQMs manually, to report Medicaid only data, should they report Medicaid member based on patient's insurance status at the end of the year? Anyone have an answer for that question?
I don't think I have an answer. I was kind of waiting to see if Nathan or Megan maybe did.
Nicole, do you have, how would you handle it, Nicole? I would probably turn to Nicole for that one. But Megan, you can probably weigh in on it as well.
So I can let you know that Contexture is pulling the updated Medicaid attribution list and putting that side by side with the MRN list on a monthly basis. And so when we're doing year-to-date care gaps, it'll be on the most recent attribution list.
And this is Emma from QHN. For our baselines, we are using the end of year 2022 Medicaid eligibility file, and our plan for 2023 is to use the end of year Medicaid eligibility file. So we are using the end of year file to calculate.
Great, thanks for that clarification. All right, any other questions or concerns? Don, I see another comment in the chat about Practice Fusion and its limitation. I'm wondering, Don, do you want to come off mute and share a little bit more verbally about your system and the barriers that you're encountering there?
Hi, good morning, everyone. Yes, Practice Fusion is very, very challenging to report measures. I have worked with a few of you in the past. Jane knows my struggles very well. And Practice Fusion cannot separate Medicaid from commercial payers. It's all or nothing. And I have explored the opportunity of looking into other vendors, and many of them charge upwards of $700 to $900 a month per provider. And they really don't offer much in the way of added benefit. And for smaller practices, this is pretty much cost prohibitive.
Thanks for sharing that, Don. And we know that EHRs can be very pricey, and that's definitely a consideration in the cost of doing business for any practice. Any other small practices on the line that want to chime in on your experience with your vendor? We know that this is particularly challenging for small practices that may not have the resources that some of our bigger systems have. So definitely want to hear from you this morning or offline. You can email us at any time at focusgroups@coloradohealthinstitute.org. All right, we have another question from Emily. For the Medicaid-only data submission, would it be Medicaid members attributed or all Medicaid members seen?
I can answer this on what the HIEs are doing. So Medicaid members, the attribution list is the initial population. But when you're looking into the denominator specs of an ECQM, it's going to be those with an encounter, a qualifying encounter. So the denominator is going to be those with like a 99213 that are seen for their physicals. So that's what's going to be. But the attribution list is like the initial population. If that helps answer that, Emily.
Thanks for that clarification. All right. And we're hearing from Mike that similar to Don, his EHR does not have the ability to report Medicaid-only CMS measures, also not sending complete CCD data to Contexture, so we're at a definite disadvantage. Our doctors' owners have no plans to switch to another EHR. Thanks for chiming in on that, Mike. And also another second on the limitations of Practice Fusion. And a question from Christina. Wondering if there's any financial resources to support the integration with Contexture and Practice Fusion. Nathan.
So unfortunately, due to federal funding limitations, the department cannot provide funding for EHR integrations. But I think there might be some opportunities out in the world to do that sorts of work. Megan, you might be aware of some of them.
So we currently have a program where to send us data to Contexture, we do not charge for that. And so we could work with a vendor, and for Practice Fusion in particular, we can make it his connection. Some vendors do charge like monthly fees to connect. It really depends on the vendor, and each one is different. So we can have further discussions, and I can drop my email in the chat, and anyone that has questions can reach out to me and we can follow up individually.
That'll be great. Thanks so much, Megan. And I do want to emphasize, I think we've made this point a couple of times already, but just underscoring the challenges that we know practices are facing in this. There are still many other measures to choose in APM1, so there is still opportunity for practices to succeed in APM1 in the quality model around these challenges. And the reason we're talking about this so much today and have devoted an entire session to this issue is that ECQM reporting is really important. It helps us get to more outcomes in theory, if we can get it all figured out. And the department is really interested in the Medicaid-only population. And so we want to move in this direction. We realize there are challenges. We have resources with Contexture, QHN, CCMCN to keep moving in this direction. And we anticipate this being integrated more and more into future programs. And the department will continue to consider all of the great points that you guys have raised today. So I just want to emphasize once again that this is a journey and there is still opportunities to succeed even with all of these barriers. This is not, we're turning off all other measures except ECQM. And if you can't do it, you're out of luck, right? This is very much the next step in the process to try to get some of these systems set in place so that we can rely on them more in future programs. I don't know if anyone from the department wants to layer on additional considerations on what I just said.
I think you did a good job, Ashley. But yes, we're just trying to, we're going to be using 2024 really to, see what our data capabilities are across the state, which is why that Medicaid only file, if you are able to submit it. So looking at you all electronic reporters that are able to really determine if paying for Medicaid only ECQMs is feasible. We need a lot more data to make an informed decision. And I will probably just leave it at that, but we really just need that data to make our decision. And that's why it's so important. And I know it was required this last year, but we did not put nearly enough emphasis on it. So it will be in the guidebook again, but we've had a whole meeting dedicated to this. So it is, just know the importance of it. I don't know if Pete had any final thoughts on this.
No, I really, no, I echo what you just said, Zoe, and I would just say, as Ashley pointed out, we appreciate your engagement in this meeting. We've listened closely. We felt it was important to be transparent about the direction we're going. And again, we're not doing this tomorrow, but the part we're committed to is hinging our value-based purchasing programs and APMs off of Medicaid performance for our members. And so we know, and I think this meeting has highlighted many of the trade-offs involved in the different options. So we really, though, do appreciate your engagement and the feedback you've given us. And we hope that at least you understanding our direction in the future is helpful to you as well.
Yeah, absolutely. We do have one more technical question in the chat. I think it was a direct message to me only, about the eligibility churn and how that is working with people who were on Medicaid but then are no longer eligible, halfway through the year in September, et cetera. And I believe the answer we've heard from QHN and Contexture is that they're doing this at year end. So people who are enrolled in Medicaid at the end of the year are included. Does that mean that people who were enrolled in February are excluded from the calculation?
I don't know if I can answer that for ECQMs, but for administrative measures, each measure has its own like continuous eligibility requirements. So you would have to read the measure specifications, which are on the APM1 website to know for each measure if a person will be counted in the denominator or not.
Great, thanks for that clarification. So it is measure specific on eligibility. Dr. Walsh, I see your hand up.
I was about to lower it. Zoe answered the question.
Okay.
And I would just say that if you want, Ashley, if you plan on doing follow-up postings after the meeting, we could address it properly globally. But Zoe's exactly correct. Depends on the measure, clearly specified in the measure specification, which is what we follow. And we need to correlate that with the ECQM, the methodology for that. So if you want to, we could maybe do a 1-paragraph follow-up on that captures the ECQM part of that. But the answer regarding administrative measures is it's very specifically defined in many measures, the need or not need to be continuously enrolled.
Great. Thanks for that clarification. Barb.
Thank you. Thank you. My question or basically comment or ask of HCPF is in my facilitation and in my team's facilitation of the HCPF APM program previous few years, we get a lot of questions regarding coding and how to code and how to really make the work they're doing count, that these PCMPs are doing, and get credit within those administrative measures. Is there opportunity like QHN and Contexture are doing in supporting and helping? Is there an opportunity for HCPF to provide some sort of webinar or trainings to the PCMPs to help support them with those measures and the coding?
Yeah, I think that's a great idea. Dr. Walsh.
I think we'll need to take that back to understand. I think at a very minimum, you make a good point within the constraints of those of you. In fact, I think a lot of you are very aware of how HEDIS works with regard to licensing. But we've picked measures that are CMS sponsored, so we need to evaluate to make sure they're readily available online, and the degree to which we can. We'll have to evaluate our ability to support seminars or something like that. But you ask a good point. Some of this is, there's a massive technical aspect of this, which is what we've talked about literally for the last hour and a half. But there's also, to your point, your provider, and ideally this can happen transparently. But the reality is, there is the other option. It's called Mark 1. Check the box electronically or on your coding sheet of which G code applied to their hypertensive control, diabetes, or why you did or didn't, or what kind of formulate a follow-up plan. So you're right. Some of this is literally not even one-pager stuff, which you can find online for many insurers, but we'll look into that. That's a good point.
Awesome. Thank you, Dr. Walsh.
All right, and then I think that's a good transition to Don's comments in the chat around timeline and action steps going forward. So we'll bring up the slides again to show you what happens next. But in summary, as we've discussed throughout this this morning, the reporting of Medicaid-only data is required under the program right now. It will continue to be required given all of for those who have selected ECQMs, right? So there's still that element of choice under APM 1 that if you are selecting ECQMs, you are also required to submit that Medicaid only data. The purpose of that is to really inform the department's decisions moving forward for future programs, to make sure that this data is reliable for future purposes. The next step for the APM 1 engagement process is our next community forum next Thursday that will talk about health equity. And then we also will be, that will be the end of this series of APM 1 specific measures for the next program year for APM 1. There will also be future opportunities to engage in all of these future programs that we have alluded to throughout the call. So we'll put the link in the chat for how to sign up to get more information about that. And I will hand it off to Mariah for any closing points that I have forgotten to add here.
Thanks, Ashley. You're so wonderful. Yes, so just again, any written feedback that folks may have, please submit it to us by Tuesday, the 17th. You can reach out to Zoe at zoe.pincus@state.co.us, or myself at focus groups at coloradohealthinstitute.org. And just what Ashley referred to is that you can sign up to learn more from CHI about future HCPF programs, especially the value-based payment work that we're doing in the future that Dr. Walsh was referring to early on as well. You can use that little scan code or utilize that link that has just been put in the chat as well. And that brings us to the end. So thank you all so much again for your time today. And we look forward to your participation and questions in our next session.
Thank you, everyone.